and mute those that are currently not speaking, i.e. the presenters. But there is a chat box, which I'll point you to in a minute. So let me go ahead and turn it to our presenters. If you guys could introduce yourself. Let's start with Gloria.
Yeah, my name is Gloria Coronado. I'm an epidemiologist at Kaiser Permanente Center for Health Research.
Great. Thank you, Gloria. And then Gretchen.
Hi, I am Gretchen Caplener, and I am the Health Systems Manager for the state of Oregon. My focus is on primary care, and I work with the American Cancer Society.
Excellent. And then Lynne.
Hi, it's Lynne Frost from Oregon Community Health, and I'm the Clinical Operations Director here.
Great. Excellent. So these are the three presenters that are going to be presenting today on our session. So this is Learning and Sharing Session, Colorectal Cancer Screening, Statistics and Effective Practices from Local and National Efforts. So before I dive into today's session, I thought I'd throw up a slide here really quick just to talk a little bit about who we are, Oregon Primary Care Association, since there's some of you on the phone that I know aren't from FQHCs, I think. So OPCA is, we are the state's primary care association. We provide technical assistance to Oregon's federally qualified health centers. We learn from, educate, and influence health policy at the state and national level. And our mission is to lead the transformation of primary care to achieve health equity for all. So a couple logistics. So as I mentioned, I've been muting people as they come online, but that doesn't mean that you can't share your feedback, of course. So if you look on the right-hand side of your screen, you should see a little GoToMeeting box. And at the bottom is a little chat box. We are leaving 10 minutes for Q&A at the end after our presenters talk about colorectal cancer screening. So if you have any thoughts while they're speaking, definitely feel free to type it in at the bottom in the little chat box, and we'll address all questions at the end. Okay, so today's topic at a glance. So many of you are here probably partially because of the Data Transparency Initiative. So for those of you that aren't aware of that initiative, OPCA has organized a data transparency initiative where essentially Oregon's 32 federally qualified health centers share with each other their own data and discuss best practices. So within, as part of this project, the executive leadership of Oregon's FQHCs have chosen certain measures that they think are really, that are primarily the one that a lot of their centers are focusing on. And these measures are the ones that centers review and discuss and learn more about in conjunction with other FQHCs across the state. One of the metrics that has been selected for this project is colorectal cancer screening. So a couple things for today's session. So we're first going to start off with a little bit of a brief introduction around the statistics around colorectal cancer and then also screening rates. So that'll kind of put a good a frame around this particular screening measure and really emphasize why it's important for FQHCs to screen for colorectal cancer. We'll also learn about local and national initiatives, best practices, and tools for improving screening rates as well. Gloria is here, and she'll talk a little bit about this Stop CRC initiative, which I believe some centers on the phone are participating in as well. And then finally, we'll see an example of how one clinic, in this case, One Community Health, has really tackled colorectal cancer screening as a metric as a center, but also in participation of the Data Transparency Project. So before I turn it over to our presenters, I thought I would throw up just really quick the Oregon Health Authority CCO definition for colorectal cancer screening. So this will be in your slide deck. We will send this out afterwards, but it's always helpful to just toss the definition up there just to get an idea of what centers are looking at. So this is a CCO metric, so it is specific to Medicaid patients, but how this affects FQHCs is that a lot of FQHCs are working with their local CCOs to improve this particular metric. Here's the second piece. You'll notice the FOBT, the flexible sigmoidoscopy, and then also the colonoscopy value set. These are different ways of screening for colorectal cancer screening, and you'll hear more from Gretchen, Gloria, and Lynne about this. But also, in addition to colorectal cancer screening being a CCO metric, it's also a UDS metric. So FQHCs, as you all know, report on an annual basis to HRSA a set of different quality metrics. I thought I would throw the UDS definition for this measure up there. And you can see that it's very similar to the colorectal cancer screening metric for the CCOs. However, there are some very notable differences. So one, just a few things to know. So the CCO metric, again, is primarily focused on Medicaid patients. Also, the way in which the data is gathered is done a little bit differently. Currently, the CCOs are doing chart audits, and it's also linked through claims. And then also, there's a little bit of a difference in that the CCO metric differentiates between the FOBT and the IFOBT screenings as well, which I think Gretchen will talk a little bit about in terms of the FOBT versus like the FIT, for example. And then the UDS metric, the big thing to know about there is that the UDS data doesn't differentiate between the types of tests or samples gathered when it comes to the FIT kit and the FOBT. So, you know, even though both of these measures are a focus for many FQHCs, there are some slight differences for the CCO metric and the UDS. But in general, often if you do some best practices around the UDS metrics, you will inevitably improve your CCO metric as well. We're getting a little bit of feedback. I'm going to mute. Okay, and colorectal cancer screening, benchmarks and statistics in brief. So I thought it'd be helpful to share just where we are as a nation and then also where we are as a state. So National Colorectal Roundtable, which is an initiative, and Gretchen, I believe, is going to talk about that, but if not, we can send some information to you. So one of the benchmarks is that 80% of eligible patients will be screened by 2018. The Healthy People 2020 benchmark is 70.5%. And then the CCO benchmark in Oregon is 47%. And just to provide a little bit of information of where we are currently, for FQHCs, the national screening rate as of 2013 through UDS data was 32.6%. And then for Oregon, specifically, it was 27.9% for 2013. So I believe we just got the 2014 data, and I'm not sure if things have or have not improved. We can probably...
They've improved slightly, but I don't have the numbers in front of me right now.
Okay. But either way, we'll send that out afterwards. But you can see there's a lot of good work to be done, and thus we're happy to have this call to introduce some of these best practices. So with that said, we're right at 11:10, and I'm going to turn it over to Gretchen from the American Cancer Society, who's going to share some statistics and information. So Gretchen.
Thanks, Krista. You can go ahead and advance to the next slide. So I'm Gretchen Caplener. As I said, I work with the American Cancer Society, and one of my roles here is to focus on colorectal cancer screening. Today, I will provide a brief overview of some national statistics, review resources, and tools available to you. My email and phone are up on the screen now, and I'm very happy to meet with you individually and talk about specific projects or do specific trainings with you. There's a lot of information around colorectal cancer screening, so I'm sure we could talk for more than 10 minutes about it. Next slide. The information provided today is available in the American Cancer Society's 2015 Cancer Facts and Figures annual report, so you can log on to cancer.org and retrieve it there. So colorectal cancer is the third most common cancer in both men and women. It's estimated that 49,000 deaths from colorectal cancer are expected to occur in 2015. Colorectal cancer is the third leading cause of cancer death in both men and women, and the second leading cause of cancer death when men and women are combined. Mortality rates for colorectal cancer have been declining over the past 20 years. From 2007 to 2011, the overall death rate declined by 2.5% per year, and this trend reflects declining incidence rates and improvements in screening, so in early detection and treatment. Next slide. So incidence rates, like I mentioned, have been decreasing for most of the past 2 decades, which has been attributed to both changes in risk factors and the uptake of colorectal cancer screening among adults 50 years and older. And a quick reminder, colorectal cancer screening tests allow for the detection and removal of colorectal polyps before they progress to cancer. So beginning at age 50, men and women who are at average risk for developing colorectal cancer should begin screening. And screening can detect colorectal cancer polyps, which can be removed before they become cancerous, as well as cancer at an early stage when treatment is usually less extensive and more successful. The American Cancer Society screening recommendations are available online. I'm also happy to provide them to you, and they certainly include both FOBT and FIT tests. We do have a handy one-page clinician's guide about FOBT and FIT, so I'll shoot that over to Krista to maybe supplement my presentation today. Next slide. The 5- and 10-year relative survival rates for people with colorectal cancer are 65% and 58% respectively. So when colorectal cancer is detected at a localized stage, the 5-year survival is 90%. However, only 40% of colorectal cancers are diagnosed at this early stage, in part due to the underuse of screening. So if the cancer has spread regionally to involve nearby organs or lymph nodes, by the time of diagnosis, the 5-year survival drops to 71%. And if the disease has spread to distant organs, the 5-year survival is 13%. So this just really highlights the importance of screening and early detection for colorectal cancer. I'm not sure if you can really read it on this slide, but relative survival is the percentage of people who are alive in a designated time period after cancer diagnosis, so usually 5 years, and it's divided by the percentage expected to be alive in the absence of cancer based on normal life expectancy. So it does not distinguish between patients who have no evidence of cancer and those who have relapsed or are still in treatment. And so while 5-year survival rates is useful in monitoring progress in early detection and treatment of cancer, it does not represent the proportion of people who are cured because cancer deaths can occur beyond that 5-year diagnosis. Next slide. Here's a map of colorectal cancer screening rates. Hopefully it'll come up here in the next slide. In health centers across the country. And there might be a little lag here. So there, once you see the map from the northeast corner, there are some dark blue states who, there we go, are achieving screening rates of 42% or higher. So I reached out to my colleagues in what we call the New England division and kind of asked them what their thoughts were. So in general, they reported back they have good access to screening programs as well as Medicaid expansion. Most of the states over there, except Vermont and Rhode Island, have had CDC colorectal cancer program dollars, and those dollars were granted to the local Department of Health and then to the PCA, who work screening rates, and they're focused more on their infrastructure, so EMR modifications, patient navigators, things like that. And then in Massachusetts, they have also seen increased screening rates in FQHCs and health centers, mostly to the onset of expanded subsidized health insurance, a precursor, as we know, to the ACA, and it really resulted in 97% insurance coverage. So in addition to that, a lot of the health centers have adopted a model of using patient navigators to support patients in completing screening. Alternative, and there's as an alternative. Next, I'm going to kind of transition into some tools for primary care practices to systematically improve their colorectal cancer screening rates. The National Colorectal Cancer Roundtable, as was mentioned before, the 80 by 2018 group, and the American Cancer Society, they were working collaboratively to create tools to help unify effort and really reduce duplication of effort around colorectal cancer awareness and education. So some examples of materials that are available online are like screening algorithms, a sample FOBT flowchart, brochures, sample patient reminder letters, pamphlets, videos for patients, things of that nature. Next slide. So you'll be receiving the slide deck, and in it there are these hyperlinks to a lot of different resources that might be beneficial for you in your practice. You can find all of our evidence-based tools, resources, and publications online at either you can go to nccrt.org or you can go to cancer.org/colonmd. And these resources are continually updated. New items are always being added, and there are also sometimes included opportunities for online CMEs. Next slide. So this flowchart that you'll see outlines steps involved in creating a highly successful screening process in your clinic and within your medical neighborhood. You may already be practicing some of these steps, and this chart then can really be useful when reviewing your current processes to identify some opportunities to maybe refine or improve your screening rates. So you can take a deeper dive into each of these steps, and the manual, which is one of those hyperlinks in the previous slide, is called Steps to Increasing Colorectal Cancer Screening Rates, a manual for community health centers. And each step has the tools and resources built out to help you in whatever improvement cycle you might be working on. So you might find sample screening policies, sample notification letters to patients with negative FIT tests, a patient navigator checklist, and even some counseling scripts to help providers make a strong recommendation for screening. We know that when providers make a strong recommendation for colorectal cancer screening, it makes a big difference in getting patients to adhere to that recommendation. So next slide. This screenshot is taken from our communications guidebook. So we just released this a couple months ago. And I'm calling this out because many of our patient-focused messages can be further refined to better communicate the importance of colorectal cancer screening. So this guidebook is based on some market research from the American Cancer Society with guidance from the National Colorectal Cancer Roundtable and their Public Awareness Task Group. So the guidebook is designed to help educate, empower, and mobilize 3 audiences who are not getting screened for colorectal cancer. So folks who are newly insured, people who are insured but might be procrastinating, or those who might have some financial challenges. And the goal of this guidebook is to really share what we know about reaching these hard-to-persuade groups using some tested messages. So you can, again, use the link in the previous slide to access this resource. Or, of course, you can always shoot me an email and I can get it to you. And the guidebook reviews what we know about, like I said, producing some messages to ensure that people do get screened. And it provides tools like infographics, social media messages, banner ads, and even some medical office slides that you could run like in a waiting room or something like that. So our hope is that partners can take the research and the messages provided in the guidebook and make the message resonate with target audiences within your clinic, even more so by using your own creativity, innovation, maybe even spokespeople you have at your clinic, but to really use the guidebook as a jumping off point. So that concludes my presentation. Again, I would really encourage folks to reach out. I'd be happy to talk to people one-on-one and give a little bit more information where needed. So I think I will turn it back to Krista.
Excellent. Thank you so much, Gretchen. Fantastic overview. I'm going to pause for a second and just say a reminder of the chat box right down in the right-hand corner. So if you heard anything that Gretchen said that made you think of something or that you have a question, feel free to type it in the chat box now, and we will get to it at the last 10 minutes of today's presentation. So with that said, I'm going to go ahead and turn it on over to our next speaker, Gloria. Gloria, are you there?
I am here.
Excellent.
It's a good question. We had this power outage, so I actually had to log back in, but I made it back in time.
Excellent.
Yeah, and really wonderful introduction, Gretchen. It's really it's really great to see some data from across the country and how Oregon kind of fits into this bigger picture. And thank you, Krista and Akira, for doing such a great job in organizing this session. I'm going to talk today about the Stop CRC project, which really involves some local efforts working with FQHCs in Oregon, California, and Washington State to improve their colorectal cancer screening. Stop CRC uses a direct mail approach because patients don't need to come into the clinic to do colorectal cancer screening. They can do it at home. And a direct mailed approach can be a nice option for clinics who may be overburdened with clinic visits. So go ahead and advance the slide. So my presentation follows the outline of a little bit of background on colorectal cancer screening. Although Gretchen did such a great job, I'm going to go quickly through those slides. Then I'll give you some background on Stop CRC itself, and then really talk about some clinic-level barriers and possible solutions, as well as some patient-level barriers that were noted locally. And then I'm going to conclude. So advance the slide. As Gretchen mentioned, colorectal cancer is a leading cause of cancer death in this country, and she already mentioned that there's a significant drop-off with survivorship based on the stage at which the disease is detected, with a pretty good chance of surviving if you're detected at stage 1, but a pretty poor chance of surviving if you're detected with stage 4 disease. The critical thing here is that there's an important health disparity with regard to screening, where those who've been in this country for fewer than 10 years or are uninsured, having a screening rate that's about 1/3 of what it is in the general population. And Gretchen did a great job of presenting some of the screening rates from federally qualified health centers specifically. Advance the slide. We know from Oregon that over half of the cases of colorectal cancer are detected at either the regional or distant stages, which means that the survivability for over half the people that have colon cancer is relatively poor. We also know from state data from the Behavioral Risk Factor Surveillance System that there's a significant health disparity with regard to race and ethnicity, with the overall about 57% of individuals being screened up to date with screening, whereas only 21% of Latinos in Oregon are up to date with colorectal cancer screening. Advance the slide. But there's a variety of reasons why clinics might consider endorsing FIT testing as a component of their colorectal cancer screening programs. And one of the biggest reasons is that some patients prefer fecal testing over colonoscopy. And I think the reasons are obvious. Patients may have fear of getting a colonoscopy. They may not be able to take the time off work. There may be bigger financial burdens or in doing a colonoscopy. And these are data from a collaborator out of Texas who worked with a safety net hospital system and enrolled over 6,000 patients and randomized them to receive either usual clinical practice, a free colonoscopy, or a free FIT test. And what was found was that among these groups, the highest rates of screening occurred among the group that was offered a free FIT. And so what this suggests is that even when you remove the financial barriers, patients are still more likely to get screened if they're offered free fecal testing. Advance the slide. But the next slide shows that, the other reason to think about adding FIT or using FIT as an important component to your colorectal cancer screening program is that many areas have limited capacity for colonoscopy. And what this slide shows is that in the screening colonoscopy scenario, you have a certain number of patients, some of which will have polyps, some of which will have cancer, and you have to put them through this cylinder of getting screened, and about 1 in 400 of those will be found to have a cancer. And actually, when I've spoken to the surgeons at Kaiser Permanente, they say it's more like 1 in 1,000. So you have to do colonoscopies in order to find a single cancer. If instead you start with FIT testing, you have this larger group of patients. Of course, some of them may have advanced adenomas, some of them may have cancer, and you take them through to determine who's the high risk among that group and refer those patients to colonoscopy. What you will find is about 1 in 20 of those patients will be found to have a cancer. And so you can think of it as a way to stratify your population and identify those who have the greatest risk. What we find in data that we've collected from providers and patients is that providers will say it's easier to get a patient in for a colonoscopy if they've first had a positive FIT test. And patients as well will say, I'm much more likely to get a colonoscopy if I believe that something is wrong. And a FIT test gives them kind of this idea that there's something that's wrong that needs to be checked up. Advance the slide. So in STOP-CRC, we are taking a collaborative learning approach. We have an advisory board that we've assembled that includes clinicians from 26 of our clinics that are participating, as well as EMR site specialists that meet on a monthly basis. We developed some electronic health record tools that are simply registry-based, so we identify patients who are due for screening and then are due for different steps in our stepwise intervention. And then we delivered the intervention initially as a pilot with Virginia Garcia, and now we're delivering it in 13 of our 26 clinics, and we're going to go to all of the clinics within the next month. And we've gone through this phase of refining our intervention using the Plan, Do, Study, Act cycle, as well as having a work session that allowed us to refine our EMR tools. And then we'll get into the stage of really spreading and sustaining the intervention over time. Next slide. So as I alluded to, ours is a stepwise intervention that includes the mailing of an introductory letter, the mailing of a fit kit, and the mailing of a reminder letter or postcard. And at each step in the process, some patients are removed from the list if they have an invalid address, if they call in to report that they've received prior screening, or if they complete their screening right away and they need no further reminders. And then, as I mentioned, each of the clinics are also doing an improvement cycle, typically a Plan, Do, Study, Act cycle as part of the program. So our, advance the slide. So our clinics span a pretty big geographic distance. There's several sites near the Portland area, as well as out near Bend, in Medford, as well as Northern California. And we're also working with CMAR community health centers in Washington State that are not represented on this particular map. Advance the slide. In our pilot study with Virginia Garcia, we worked with 2 clinics that have a high proportion of Hispanic patients, and they had a relatively low fecal testing rate when we initially started. So their fecal testing rate was less than 4%. But we worked with those clinics to really to test out 2 different approaches to raising their rates of colorectal cancer screening. Advance the slide. So one intervention was called the auto intervention, which simply included the 3 automated components: the mailed letter, introductory letter, the mailed fit kit, and the mailed reminder postcard. In the other clinic, we did the same 3 steps, as well as delivered a live phone call reminder among patients who hadn't been screened after a month. And what we observed was a pretty similar response rate. So overall, the response rate was about 38% compared to usual practice. And what we found is that there was no significant difference in the response rate in the auto clinic versus the auto plus intervention clinic. And since this time, I've learned a lot more about reminders and the opportunity to use automated reminders like automated phone calls, text messages, or combining a set of reminders like automated calls as well as live calls. And what we see is that there is some evidence that combining different reminder approaches actually does boost the rate of screening. Next slide. So when Virginia Garcia then rolled out the intervention to the remaining patients in those 2 pilot clinics, what we found is that the response rate was actually higher among Spanish speakers than among English speakers, which is really important to know that this mailed intervention, which can be system-wide, which can be automated, actually addresses the health disparity in colorectal cancer screening with regard to Spanish-speaking patients. And this finding has actually been corroborated by a colleague in Texas who found similar results with the mail-out program. We also saw, as expected, that the uninsured had a lower return rate than the insured patients. Next slide. We use a variety of patient-centered approaches to design our materials, and this particular piece that you see are wordless fit kit instructions, and these were developed partly because we knew that patients in these clinics would speak a variety of languages, and it's actually really challenging to do an automated program and get the right language material to the patient who speaks that language. And so we went with wordless instructions. These were developed with input from clinical staff, with members of the patient advisory councils of Virginia Garcia, as well as members of our advisory board for the project. These were published in 2013, so they are publicly available, and they're currently being used by the direct mail program that's in place at Kaiser Permanente Northwest. We also checked in, advance the slide, we also gathered some qualitative data from patients to learn a little bit more about the reasons why they did not return their FIT kit. And what we found was that there were some big differences between English speakers and Spanish speakers in the reasons that they reported not returning their FIT kit. English speakers commonly said that they had concerns about mailing fecal matter, or that they were busy or forgetful and just didn't get around to completing their FIT test. Whereas Spanish speakers were more likely to cite fear of the results, fear of being charged for the test, fear of having to get follow-up, or not having received the test as the main concerns. And so real stark differences, which I think is really important as you design and refine a program to know kind of what the different issues are and concerns are in the population subgroups that you're working with. I mentioned before that our clinics did a Plan, Do, Study, Act cycle, and I'm just going to touch briefly on those because I know we don't have a lot of time, but advance the slide. But Plan, Do, Study, Act is a common improvement process. It's used in federally qualified health centers as well as other clinical practices to improve a process or a workflow. So we asked our sites to submit a plan for doing a PDSA based on their findings to date with the Stop CRC project. Advance the slide. And so this is our summary that suggests that, some of the clinics said there's too many kids that are coming back without a collection date, and so they can't send those kids on to the lab. And so what they wanted to do was test new materials that would prompt patients to write the collection date on the kit. There were other issues like patients must drop off their test rather than mail it back in, and so this clinic was going to use metered envelopes to allow patients to return their kits by mail. Others wanted to test out, different combinations of phone calls. Some people had issues with just the number of kits that needed to go out, and so they needed to develop their staffing plan and test out their staffing plan. And so this gives you an example of some of the issues that the clinics had as they tried to implement the direct mail program and ways that they were addressing it through a PDSA approach. Next slide. So as I mentioned, the first clinic had an issue with kits coming back without the dates on them, and this was actually a 2-sample FIT kit that they were using. And so they decided to, in their introductory letter and in the insert that goes in with the FIT kit, to really be clear. So to highlight that in the introductory letter, as well as to include a new insert that pointed out how to put the date on your FIT kit. And we're still waiting to get back the results from their PDSA. I'm really curious to see if that's going to result in a greater improvement. Next slide. So in summary, the PDSA process has identified a variety of implementation issues and unintended consequences of the intervention, but it's really empowered the clinics to identify and address those local problems and could be a resource or a tool that other clinics could use as they think about implementing colorectal cancer screening programs. And it really provided us with a whole set of knowledge or factors that we weren't aware of in terms of the implementation challenges of the program. Next slide. So just briefly, I wanted to provide a quick legislative update. We have an advisory board for Stop CRC, and they've been pretty involved in helping to get some legislation passed. Next slide. And so one of the members of our advisory board is Mitch Greenlick, who's a legislature in our state government. And so he helped pass a bill in 2014 that meant that required insurance companies to treat colonoscopy as a screening procedure even when polyps are removed. So this means that when patients go in for a screening colonoscopy, that they'll not be surprised by copays or deductibles when polyps are removed while they're under anesthesia. And then the legislation that was signed into law this year in 2015 requires that insurance companies do not impose patient copays or deductibles for follow-up colonoscopies when a FIT test is positive. And so what this means is that there's no financial barrier to follow-up colonoscopy if a patient has insurance. And so this is some key legislation. We are proud to say that Oregon is one of the first states in the country that has adopted this legislation. It is being pushed nationally, and we hope that it changes nationally for every state's benefit. So in summary, we know that the rates of colorectal cancer screening are low, and they're particularly low for Latinos in Oregon as well as nationally. Screening is highly effective, it's inexpensive, it's easy to deliver, and patients prefer fecal testing, and that PDSA cycles really represent a possible solution to overcoming some of the clinic barriers to the mailed fecal testing program. and that our program can really provide evidence to support the broad adoption of direct mail programs, their long-term sustainability, and modifications and adaptations that are learned about through the BDSA cycles. And we're also collecting information about costs, which obviously is an important factor for clinics as well, and then data that can drive policy changes to support the continued use of fecal testing. Next slide. So my next slide is just acknowledging my team here at CHR, as well as other sites that have helped support this project. Thank you.
Excellent. Thank you so much, Gloria. That was wonderful. Lots of great information. So thank you, Gretchen and Gloria. You both have framed colorectal cancer screening so well. I've pulled up the next slide. Taking a moment again, so if you have any questions, don't forget to type them in the chat box about anything that Gloria just mentioned. And I think it's time to turn it on over to our last presenter from One Community Health. That would be Lynne Frost. Lynne, are you there?
I am.
Great.
So I was working on our colorectal cancer screening, looking at our rates, and decided to enlist Katie Izumian, who was a Doctor of Nursing Practice student at the University of Portland, to help create this QI study and implement the work associated with it. Next slide. Just a little bit about One Community Health. We have locations in Hood River and the Dalles. Our two main health centers offer medical, dental, behavioral health services, as well as health promotion and outreach services. We are opening a new school-based health center come September 1st at the Hood River Valley High School. We currently serve 10,000 patients over the 4 county regions of Hood River, Wasco, Skamania, and Clickatack counties. And we have over 100 people employed, including the Providence Residency, Rural Residency Program, and we use Ocean Epic as our EHR. Looking at our screening rates, what I noticed was that we really had flatlined starting in December 2013 and carrying through in 2014. That although the benchmark was 47%, we were kind of hovering between 33 and 34%, in which case this became a focus of trying to get closer to that 47%. Next slide. Looking at some of the barriers that we had, there were organizational level, provider level, and then patient level. We really had no office-wide, organizational-wide protocol for colorectal cancer screening. Oftentimes we had some barriers getting patients scheduled for routine appointments and the high volume of no-show appointments. At the provider level, oftentimes the screening was just not being ordered, whether they had a familiarity with the screening recommendations or lack of time with patients. A patient component if they were unwilling or unable to complete the testing. And then also oftentimes improper documentation of the screening. The patient might have had something that was performed outside of One Community Health, but it was not being reflected in our EHR. And then of course at the patient level, if there was not follow through with the screening order, multiple areas, financial, transportation, language, cultural, literacy levels that could impact their ability to perform the screening. Next slide. So in October 2014, we began to look at our practice really with 2 goals in mind. The first goal was improving the provider consistency of ordering and documenting the colorectal cancer screening, and then looking at the patient level of improving the patient participation in screening. The methods that we chose to use were standardizing an organizational process for colorectal cancer screening to be performed. We replaced the FOBT GLIAC-based cards with the FIT test, and then we proceeded to use dashboards in staff areas to show progress towards meeting our goals. Next slide. In looking at the FIT test, I don't really need to go into this great detail because it's been explained twice so well. Obviously, using the FIT test, moderate sensitivity, high specificity, high diagnostic accuracy, no significant difference in the colorectal cancer detection as compared with the colonoscopy. more sensitive and specific than using the guaiac-based FOBT, and more cost-effective than the colonoscopy and the FOBT. Next slide. Looking at the patient participation, what we know about FIT use is patients are more likely to participate using the FIT test compared to other methods. Patients feel that the FIT test is easier, it's more convenient, and less unpleasant than using the FOBT guaiac-based cards. Patients given the choice of tests may increase their adherence to screening, and more extensive discussion of screening with the primary care provider associated with higher screening rates using the FIT test. Next slide. Looking at how to choose between the colonoscopy and the FIT, patients in an average risk should choose their preferred method. The FIT is slightly more feasible for patients who are uninsured and have transportation or time adherence barriers. And obviously patients that are increased higher risk should receive a colonoscopy. Factors such as colorectal cancer screening in first-degree relatives, or personal history of Crohn's disease or ulcerative colitis, and the hereditary syndromes associated with it. Next slide. The new OCH screening process that we implemented was really empowering the MAs to perform a chart scrub on incoming patients before their visit to determine if the patient's up to date on colorectal cancer screening, if they're overdue for screening, a conversation between the MA and provider to discuss if the patient is eligible for the FIT or the colonoscopy, and having those orders placed into the chart prior to the patient visit. When the patient is roomed by the medical assistant, the MA is confirming that the patient screening has not been completed elsewhere, and if it has been completed elsewhere, really securing information to update the chart to reflect that when it was done. The provider goes in and sees the patient, recommends the screening to the patient, and if a colonoscopy is deemed appropriate, they would place the order at that time, and if not, they would just go and sign the order that was already placed in the chart. With the MAs going back into the exam room thereafter to go through the instructions with the patients for those using the FIT. Next slide. Looking at our evaluation, our outcomes that we were looking with the percentage of eligible patients for screening that was ordered. We were going to measure that weekly and compare to the previous weeks. The percentage of patients with screening order who completed the screening and measure that to the previous month, and the overall screening rate to see if we could increase the number from the previous month. The process was looking at staff attitudes and beliefs related to this practice change, what worked well, what could we improve, and measure that at the conclusion of this pilot study. The next slide shows the provider ordering rate. Our baseline orders were placed for eligible patients. We had about a 16.2% rate, and when we started having those data dashboards, there was a steep incline up to 36.4%, which then plateaued back down to 23.6% over time. On the next slide, the patient completion, what we noticed from the prior month, we went from 31.6% up to 44.3% when we introduced the FIT as a screening method. And what we also recognized was that the days to complete the testing actually decreased down by 4 days on average. Next slide. In summary, what we noticed was the ordering increased by 10.9% on average. Patients completed the screening by an increase of 12.7% and on average 4 days faster. Next slide just describes our next steps. We have formally created a clinical protocol that's been adopted by all providers to follow. And based off of the protocol, we've developed a clinical procedure that empowers the support staff to routinely have the ability to place these orders and promote this screening. In addition, I've used this as a quality improvement measure for the clinical support department, which allows that review those results every single month, and using PDSA cycles through that of small tests of change. It empowers more team members to be proactively involved in the improving of the health outcomes rather than just solely relying on the provider to be offering the screening. I think there's great benefit to displaying the data visually to show the change and foster completion from one site to the other. There's always been kind of a little healthy competition from one site to another, and having that visually displayed, I think, only has further advanced some of these outcomes. And then also just celebrating the victories, recognizing and rewarding the staff that's consistently been able to follow the clinical procedure, I think really help promote all the team members being vested in the outcome. My final slide, my words of advice, is just really doing small steps of change and reassess them frequently. That same notion of using the PDSA cycle over and over and over. Celebrate your successes at every single opportunity and engage staff at every level to empower their ability to work at the highest level of their scope. And I would highly recommend, if you have the ability to engage any doctor of nursing practice students to participate in this type of work. They're really focused on systems level, population-based preventative health care, and really looking to erase a lot of the health disparities that we know exist. And that's it. If you have any questions.
Thank you, Lynn, so much for your great overview of One Community Health's efforts in improving colorectal cancer screening. Fantastic. So we have about 10 minutes before we wrap up this call, so now is the time for questions. And we already have one in the chat box. And I'm going to, so you have two options. You can either type them in the chat box, or I might be brave and unmute everyone and see if we have any verbal questions. So let's see how this goes. Okay, everyone is unmuted. Feel free to vocalize your questions or type them in the chat box. I'm going to go ahead and start with the first question, though, that we received in the chat box, which was for Lynn, which was from Matthew, which was, will a copy of the protocol be available as a sample? Are you guys willing to share your protocol for colorectal cancer screening?
Absolutely. I included my email on there. If Matthew wants to email me directly, or if you want me to just send it to you, I'm more than happy to do that.
If you're open to it, I can probably send it out to the group.
That's fine.
Okay, great. Thank you. So other questions for either Gretchen, Gloria, or Lynn? Well, I have a question, if anyone doesn't have one. So this question is really for the three of you and your own general expertise around this topic. So Lynn was talking about how they switched from the FOBT to the FIT. And I know that several practices have done that. So I was wondering if one of you would like to summarize just in brief and Lynn did that in piece of her presentation, but from your own perspective, the difference between these two tests and your experiences as well with other clinics, and if they found similarly that the FIT kit is the way to go.
This is Lynn. I think the fact that the FIT test is just easier to administer, it's easier to collect the sample, there's less restrictions, dietary restrictions, medication restrictions. So there's just greater receptivity from the patient to actually perform the screening using that versus the FOBT.
Okay, got it.
Yeah, and this is Gloria. Just to echo that, when we started our project, we did not require that clinics switch from FOBT to FIT, but all of them decided to use the project as an opportunity to make the change, and they haven't looked back. So they've they all believe it's a better test, which it is, a better quality test, and also there's less restrictions. Like you don't have to avoid red meat and stop eating certain foods or take aspirin before doing the test, and so there's a lot of openness to switching.
Interesting. Thank you.
Mm-hmm.
All right.
I have a quick question for Lynne. Lynne, are you guys using any type of reminders for when you hand out FITs in the clinical setting?
No, at this point we're not. The reminder comes up in the health maintenance section in the EPIC, which alerts the staff. But at this point in time, we didn't go the additional step of having any sort of follow-up reminder. That'll be probably the next round of PDSA that we do. Right now, I'm just getting off the ground looking to see what happens with the ordering rate now that we have the clinical procedure in place. That really empowers the medical assistant to have more autonomy of getting that order placed, to see where that goes, and then I'll do a further test of change thereafter.
Yeah, sounds great.
Thank you. Okay, so it's about 5 minutes beforehand, and we're not getting any questions in the chat box, and I want to do one last call for questions and see if there's anything. And if not, I think we can probably just go ahead and wrap up early. And all of you will have the emails to us and then also the presenters as well if a question does come up. So any further questions while we're on the line? Going once? All right. We got a comment from Jennifer that just said, thank you to all the presenters, and we want to echo that. So thank you so much, Gretchen, Gloria, and Lynne, for talking about this important topic. Really excellent work, a lot of great ideas. To the rest of the group, we'll send out an example of that protocol from One Community Health. And this session has been recorded too. We'll be sending the link to the recording once we get it up there. So if you know of any colleagues that weren't able to attend today, providers, executive level staff, feel free to share this presentation with them and they can watch it at their leisure. So thanks again to our presenters, and thank you all for attending the call. And right after this, we'll send a really brief survey about this learning and sharing session, just to ask you how it went. So then we can, take that and incorporate it into the next session next time. All right, we're going to close the presentation. So everyone have a good afternoon, and we'll see you next time.
Thank you.
Thank you.